Welcome to the Symposium on Theories of Medical Decision-Making, Explaining, Predicting, and Improving Health and Healthcare. I'm Valerie Reyna from Cornell University. I was invited to organize the symposium as part of the annual meeting of the Society for Medical Decision-Making. I want to thank Alan Schwartz for all his help and all the staff and organizers. I also want to thank the many scholars who took the time to suggest scientists and theorists. They came up with a spectacular group. The speakers are Ellen Peters, Ken Resnickow, Alex Rothman, and myself, encompassing East, West, and in between. Their titles and affiliations are shown in the program, and their curriculum vitae are too long to summarize. Suffice it to say that Ellen, Ken, and Alex are among the most thoughtful and rigorous scientists conducting research relevant to health and medical decision-making today. A brief word about why the symposium is so vital to patients, providers, and policymakers. In principle, scientific theories explain why patients, providers, and policymakers make specific decisions. And because they're about causal mechanisms, theories provide guidance for the design of effective interventions for improving those decisions. Interventions that can be replicated and improved because we know something about their mechanisms of action. In practice, however, problems rather than theories often motivate research. And when theory is invoked, its application can be piecemeal and ad hoc. Thus, human behavior, on which so much depends, remains essentially a black box, exhibiting biases and fallacies that seem inevitable, and cumulative progress is stunted. We're going to address that today, and I hope that you enjoy these distinguished speakers share their exciting work.
Hi, I'm Ellen Peters from the University of Oregon, and I'm going to talk today about how understanding psychology, understanding psychological mechanisms, can help us improve health, including by questioning and clarifying theory. I'll use objective numeracy as a case, because we know quite a bit now about how it relates to how people process health as well as other information. Did you know that almost a third of Americans don't have the numeric skills needed to make effective decisions about their health and their finances? In fact, about 29% of US adults can do only very, very simple processes with numbers. They can count, they can sort numbers, they can use very simple arithmetic, and they can use simple percentages like 50%, but they can only do that if there's little text and minimal distractors around the numbers. By the end of today's talk, I hope that you appreciate the importance of numeric ability and the importance of numeric confidence to the quality of patient and consumer health decisions and health outcomes. And that you also appreciate how we can use what we know about psychological mechanisms that are important to health to question as well as to clarify theory. But let's talk first about why numeracy is important. First, the less numerate lack knowledge needed to manage their health. Imagine you take this medicine, which says to take 1 tablet 1 hour before a meal or 2 to 3 hours after a meal. You forgot to take it at 11 a.m. and you're now eating your meal at noon. And the question is, what's the earliest time that you can take the pill? Now here's where I often stop for little audience participation, but that's a bit more difficult on Zoom. When I'm able to ask in person, people often guess 2 p.m., 3 p.m., or even just say 2 to 3 hours after a meal. And all of these answers were scored as correct by the group who posed this question to a representative group of Americans. Next, I usually ask my audience how many Americans could not answer the question correctly. And I'm just going to tell you about what they found. In fact, about 40% of Americans couldn't figure out what time to take the missed medication dose, given these instructions on their pill bottle. These are numeracy questions, and they're important questions because about 70% of Americans take at least 1 prescription drug daily, and more than 50% took 2 or more drugs. And not understanding can have health consequences. One person told me, I miscalculated how long a prescription medication would last. I ran out of pills and I ended up quite ill. It can also have emotional consequences. I've been diagnosed with cancer. The numbers were very confusing and I simply felt scared. And these, by the way, are smart, educated people. They just happen to be low in number ability. The second reason that numeracy is important is that the less numerate tend to make worse decisions when numbers are involved. The highly numerate are the ones who think hard about numbers in their decisions. They seek out numbers more than the less numerate, And they do usually simple number operations, like comparing numbers, for example, while they try to figure out what the numbers mean for some decision they have at hand. Decisions of the less numerate instead are vulnerable to compelling stories, to images, and to their own emotional reactions. Because of this, they tend to perceive more risk and make worse decisions when numbers are involved. And the less numerate's worse decision-making is a risk factor for them that seems to accumulate over time and result in them being less healthy. In particular, the less numerate are 40% more likely to have at least one chronic disease compared to the highly numerate. They also take 20% more prescription medications while having less ability to follow complex medication regimens. Finally, they end up in the hospital and the emergency room more often. And so we have a series of psychological mechanisms that are linked to objective numeracy. The less objectively numerate respond more to concrete information that's easier to evaluate than numbers are. Things like compelling stories, information frames, like presenting information in terms of mortality versus survival, as well as their own emotions, but not their feelings about numbers. The highly numerate think more about numbers. They spend more time in decisions that involve numbers, and they do more number operations, like those number comparisons I mentioned, but also making simple calculations. They also use feelings, but unlike the less numerate, they incorporate feelings about the numbers into their decisions, and ultimately they're more sensitive to numeric risk and benefit levels. For example, by responding more to a 92% chance of a benefit from some medication compared to only a 63% chance. We've looked at some of these ideas recently in a longitudinal study of 891 US participants, in which we asked them about COVID-19 in 3 survey waves from February 17th to April 2nd of 2020. Based on what we knew about numeracy mechanisms, we hypothesized that those participants who were higher in objective numeracy would experience less negative emotion to the virus than the less numerate. We further hypothesized that they'd understand that taking protective measures would have a small benefit of helping if it was done once, but that it would have cumulative benefits over time, so that the highly numerate would perceive protective measures like hand washing and staying home if sick as more effective than the less numerate, and the highly numerate would be more likely to take those measures. In fact, the highly numerate did report fewer negative emotions to the virus, similar to other results we've seen with numeracy in other risky situations. So on the graph that you see now, you can see objective numeracy on the x-axis, and on a scale of 1 to 4, the average negative emotion that's experienced, depending upon the participant's numeracy level. However, inconsistent with our initial hypothesis, they also reported protective behaviors as less effective than the less numerate, and the highly numerate said they were less likely to take those protective behaviors compared to the less numerate. And the question is why? Why would that be the case? We do know that the highly numerate, measured as we tend to measure objective numeracy, are not perfect with numbers. Some numeric operations that are important to health are much harder than a typical highly numerate person can do. And it could be that COVID-19 statistics have been in fact, we know that COVID-19 statistics have been difficult for most people. In this case, what may have happened is that the highly numerate may have failed to appreciate the cumulative benefits of the protective behaviors. This could be consistent with them perceiving them as less effective than the less numerate, who just want to have a solution and go with it. The highly numerate also took a more distanced, less immediate perspective on COVID-19 based on an analysis we did of writing styles in open-ended questions in the surveys. The highly numerate used longer words, and they had fewer references to themselves as well as to the present time. And this perspective difference then may have resulted in different levels of emotion experienced, with cold cognitions and perhaps incorrect calculations for the highly numerate, and hot cognitions for the less numerate, then guiding further thoughts. And for the highly numerate, despite their clear cognitive advantages, the highly numerate making what public health officials would characterize as worse decisions about protective behaviors. Knowing this, studies of health communications then could target either or both mechanisms and examine effects on protective behaviors. Objective numeracy is not all that matters though. Numeric self-efficacy, I'm going to call it numeric confidence, matters too. In fact, it's a major driver of behavior change, and persistence in the face of obstacles. In 3 studies now, we found that with high numeric confidence, objective numeracy relates more to outcomes and behaviors than it does for those with low confidence. We tested this idea, for example, in a group of lupus patients who gave us permission to access their medical records to see how active their disease was. And then we looked at how well the patients were doing based on objective numeracy, as well as on numeric confidence. Here are the main results of that study. On the y-axis, you'll see the disease activity scores for these patients. And those scores range from 0, which is great. Lupus patients want to have little to no disease activity, all the way up to 16, which I'm not showing on the scale. But 16 in those higher numbers are not good. In fact, one thing to note is that a score of 6 or higher is thought to need medical intervention. On the y-axis are the patient's objective numeracy scores. More numerate patients are on the right, less numerate on the left. And then patients who are higher in numeric confidence are depicted with the solid line, and those with lower confidence are depicted with the dotted line. What we can see is that objective numeracy matters more among highly confident patients. The solid black line, you might notice, is less flat. It's more steep than the dotted line. Among the highly confident patients, the solid line that you can see, if they have high objective numeracy, they do particularly well. They have lower disease activity. However, if they have low objective numeracy, they do particularly poorly. They have, in fact, the highest disease activity. That's those people who have high numeric confidence but low objective numeracy. Ultimately, among those with high objective numeracy, having high confidence helped. They had lower disease activity. But among those with low ability, having high confidence hurt. What we think happens is that individuals who are higher in numeric confidence, they play a more active role in their health decisions and actions. If they also happen to have the objective skills to successfully navigate the numbers that they need to use in health decisions, then they can flourish. We replicated this same pattern in a greater role for objective numeracy among those who are more numerically confident in 2 other studies, in American self-reported financial outcomes, and also in the COVID-19 protective behaviors that we discussed a moment ago. And these results suggest that psychological mechanisms linked to objective numeracy may be exacerbated among those with high numeric confidence who go out of their way to use numbers, for better or for worse, depending upon what their abilities are. Objective numeracy findings are generally consistent with dual process theories. One of the more popular theories, like System 1 and 2 from Kahneman and others, suggests that thinking slow from System 2 should produce better decisions. And it makes some sense to think about objective numeracy skills as being part of this deliberative slow system. Math skills appeared quite recently in our evolutionary history. And in fact, higher objective numeracy is usually related to better decisions. However, some numeracy data are inconsistent with this dual process theory. That more numerate people sometimes make decisions that are worse than the less numerate. And there are a few examples goes against this theory, as the idea that System 2 through objective numeracy can inform System 1 feelings. That interaction between System 1 and System 2 is not allowed in these default interventionist theories. Numeracy data are more consistent with fuzzy trace theory, with the highly numerate being more expert with numbers, producing more gist representations, those feelings about numbers that we discussed briefly, and usually making better decisions. Inconsistent with fuzzy trace theory, however, is that those who are higher in objective numeracy do more verbatim operations in at least one study, and those verbatim calculations drove judgments more than gist representations did. In addition to that, the role of numeric confidence is outside the scope of both theories that simply don't consider it. So what are the key takeaways? First, many people are innumerate, and they're vulnerable to the power of compelling stories and images and emotions, which often conflict with the data-based information that's important to making high-quality medical decisions. In these situations, if a patient is bad with numbers, he or she likely will be bad with decisions, although numeric confidence matters too. Our theories should be able to explain these processes and ultimately shine a light on what interventions will work best. Box once said that all models are wrong, but some are useful. These theories are useful. Understanding and targeting mechanisms is also useful to improve theories and ultimately to improve health. And this is critical today when individuals are the ultimate actors in making decisions about their health. Thank you very much. If you're interested in learning more about numeracy, including in health domains, please check out my new book, In Numeracy in the Wild.
My name is Ken Resnikow, and I'm at the University of Michigan School of Public Health, School of Medicine, and the Rogel Cancer Center. Today, I'd like to address one key question: is shared decision-making right for everyone? Let's begin with a survey that Levinson et al. Conducted in 2002 and published in 2005 amongst about 2,800 US adults. They asked this representative sample about 3 components of shared decision-making. Please take a look at the 3 items. What they found is there were differences in preference for shared decision-making across socio-demographic categories. Women, more highly educated, and those who are healthier preferred a more patient-driven shared decision-making, whereas African Americans and Hispanics preferred more provider-driven shared decision-making. So this paper establishes that there's heterogeneity in patient preferences for shared decision-making style based on sociodemographics. It doesn't address, however, whether actually matching shared decision-making style on the part of the clinician to patient preferences impacts outcomes. In order to address that key question, I need to sprinkle in a little bit of theory. Self-determination, or SDT, has been around for about 30 years. There's over 3,000 publications on this theory, and it is one of the most widely validated theories of behavior change. One of the key observations of SDT is there are 2 types of motivation: autonomous and controlled. They differ in quality. Autonomous motivation is considered higher quality. That is, behavior change or behavior processes that are initiated through the autonomous pathway are more enduring than those that are initiated through the controlled pathway. And the autonomous pathway and the controlled pathway have both a process element, that is a volitional component, and a content component, which for us includes values concordance. That autonomous motivation tends to be values concordant, whereas controlled motivation tends not to address values concordance. So in this way, we think that autonomous and controlled motivation map pretty nicely into patient-centered shared decision-making versus more directive provider-driven decision-making. So a simple interpretation of SDT is that we should give everyone shared decision-making. It's simply a higher quality process and has essential content, the values concordance, that is basically good for everyone. SDT also would posit that provider-driven decision-making using controlled motivation, a directive tone, and is not values concordant should be less effective for everyone. But is it so simple? Does it pay to actually match communication, process, and content to patient preferences? To do that, we're going to start with a tangential study. This was an intervention we did on fruit and vegetable intake a few years back, where we randomized 500 African American adults to get either a pull intervention, which I'll describe in a minute, or a push intervention. We recruited people in Detroit and in Atlanta, and we followed them for 3 months and we measured their fruit and vegetable intake after they received 3 tailored newsletters. In the experimental arm, we matched message tone to their push or pull preferences, and we made the intervention content values concordant. In the control arm, everyone got push tone, which I'll describe, and there was no values concordance tailoring. So in that way, the arms differ both in terms of process and content. In this arm, we matched the tone, and this arm, everyone got push or directive, not shared decision-making. And in this arm, we discussed values concordance and tried to link the behavior change of fruit and vegetable intake to their values. And in this arm, we did not address values. So when we talk about push and pull tone, notice in the directive tone, or what we call the push tone, we use language that is quite definitive. You must, you should, you have to, better, it's important, it's controlling language. Whereas in the pull arm, it's more tentative. There's more questions, there's more elicitation from the patient, it's less definitive, and it's in general more conducive to an autonomous decision-making process. So to show you how in the experimental arm, the values concordance, which everyone got, differed by tone. Here in the push tone, we provided the participant with the thoughts. We did the central processing for them. Whereas in the pull arm, we suggested one way to connect their values to their behavior, but they did the actual work. They did the contribution of effort. They did the shared decision-making of why should they change their diet. Now, we also measured at baseline their preference for directive versus autonomous communication. Disagreeing with this item, autonomy preference. Agreeing with this item, directive or low autonomy preference. And here's what we found. When we look at change in fruit and vegetable intake, those in the experimental arm that got tailored on process and content, who were autonomous preference at baseline, they changed 1.1 servings of fruit and vegetable over the 3 months. Whereas those who preferred autonomous but got the controlling tone in the control arm, or the push tone in the control arm, they did worse. They only changed 0.43 servings, and this is a significant interaction. Interestingly, those who preferred directive, which were actually matched in the control arm, and they got a matched intervention also in the intervention arm, showed no difference, which is somewhat consistent with what we would have predicted. So what this study shows is that autonomy supportive messaging, which included both manipulations of tone and content, was more effective than directive messaging for those who had an autonomy preference. In the red line group, that is the group that preferred a more directive message, adding meaning, that is in the experimental arm, values concordance, had no impact, did not improve outcomes. That line was flat. So it didn't matter that in the control arm they got push tone without values, and in the intervention arm they got push tone with values. Their effects were the same. A logical conclusion from this study is that just give everyone autonomy style. There was no harm in giving people who preferred push tone and no values, giving them the values. But let's look at another study to help further refine our question. Here, we asked about 1,700 women with localized breast cancer, recruited from 2 SEER programs, one in Georgia and one in LA, about their decision-making process about their primary breast cancer treatment 9 months after their diagnosis. We measured 3 core variables: decision quality as the dependent variable, and 2 predictors: clinician communication style and preference for shared decision-making. This is our measure of decision quality. We published it a few years back and have used it in several studies. You can take a look at the 6 elements of a high quality decision. Again, this is the dependent variable for this study. Then we use the HCCQ, a modified version that has been used in self-determination research and in MI research, motivational interviewing. And it's a patient report of their provider's autonomy support. In this case, we would map this onto patients' report of their provider's shared decision-making style. And then finally, measured patient's preference with an item that you've seen a similar version from the fruit and vegetable study. So let's take a look at the results. We're going to just today look at the surgeon results. So overall, when patients reported that their surgeon was autonomy supportive with the HCCQ, their decision quality was higher than when they reported their provider was not autonomy supportive. So there's a main effect that when patients see their provider as being autonomy supportive, they have higher decision quality. But there's also an interaction term in this table. That effect was greater for people who preferred the autonomy supportive or non-directive style. For them, the difference was 0.42, whereas for those who preferred a directive style, although they still did better when their provider was rated as autonomy supportive, that difference was only 0.2, and this is a significant interaction. So this study tells us that autonomy supportive provider communication as rated by the patients leads to higher quality decision making for everyone, independent of their baseline preferences. However, providing autonomy supportive style for those with a directive preference didn't cause any harm, and the difference was greater. It was more effective or associated with better decision quality amongst those who had an autonomy preference. Again, this doesn't support the notion that there's any harm of providing autonomy supportive decision making to those who say they don't want it. Doesn't support a matching approach. So is there any evidence that mismatching directive with autonomy tone or content causes harm? There is. And it's a study of smoking cessation that we published earlier this year. We took 204 smokers and who were randomly assigned to either motivational interviewing or health ed, which we will in a second map this onto shared decision-making, more directive decision-making. Each intervention was 4 sessions over 18 weeks, and the main outcome for this paper is quit attempts. So the 2 interventions are MI, which you've probably heard of, motivational interviewing, which is highly autonomy supportive, and health education. We have, for the purposes of today's presentation, mapped MI as an autonomy supportive shared decision-making approach and health education as a more directive, provider-driven, persuasive approach. What we found was somewhat surprising. Amongst non-African Americans, who were mostly white in this study, there was a slight, although non-significant, benefit on quit attempts of motivational interviewing versus health education. However, amongst African Americans, there was a significant benefit of health education over motivational interviewing. That was not something we anticipated. We did, luckily, measure at baseline their preference for communication style. In effect, preference for MI versus health education. Overall, we found that African Americans were more likely to prefer the directive style than whites, 58 versus 37. More importantly, when you look at almost all the study outcomes, we only looked at 1 so far, quit attempts. So when you look at all the various outcomes, in general, white folks or non-African Americans did better with MI and African Americans did better with health ed. What we found is once we adjusted for that simple single item preference measure, I want my provider to tell me what to do, all those differences were washed away. So it turns out that this study establishes that African Americans may respond better to a more directive style, and it is driven by a preference to be told what to do. So let's answer 2 important questions before we conclude. Can directive intervention ever be autonomy supportive? Can we reconcile this finding with self-determination theory? And the simple answer is yes. If the patient has volitionally ceded to their provider or requests directly a directive message or a directive intervention, we feel in this case it is still autonomy supportive. And more importantly, is there actually a justification for not using shared decision-making? Can autonomy support, which we're equating to shared decision-making, ever be contraindicated? To answer this question, we have to jump to a second theory, and that's our difficulty by motivation theory. Basically, our theory argues there are certain states and traits for which shared decision-making is not going to be effective. These include low energy states. Shared decision-making requires energy, requires input, requires attention on the part of patient. If they're in a state, be it depression, or they feel they have no confidence in this particular topic or no confidence in their ability to make the change, or they're overloaded or distracted, perhaps they were just diagnosed with a serious illness, or they're in a very aroused state. In all of these states, we feel shared decision-making may not be the most productive pathway because the patient doesn't have the energy or focus to fully contribute. Similarly, there may be cultural or personality attributes such as a desire or an expectation among some people. For example, older immigrants from Asia and from Central and South America, we have found, tend to expect their provider to be an expert, tend to expect their provider to tell them what to do. And if not, if there's too much shared decision-making, they may actually lose source credibility and the patient may be less responsive. Where does this leave us? I think there are 3 priorities for future research. First, I think we need to improve our measures of patient preference and predisposition to shared decision-making. Second, I think we should explore how shared decision-making may differ for single-shot behaviors such as treatment decisions and vaccines versus things like chronic disease behaviors like diabetes and obesity. The matching process may have very different implications across these 2 very different types of decisions. And finally, I think we should continue to explore well-designed studies using matching and mismatching approaches based upon both preferences that we measure as well as sort of latent propensities we may discover that may predict whether or not someone responds better to traditional shared decision-making or more directive approaches. Thank you for your time, and I hope to entertain some questions from you shortly.
Hello, I'm Alex Rothman from the Department of Psychology at the University of Minnesota, and I want to thank you for taking the time to join me for my presentation. I'd also like to thank Valerie Reyna for her invitation to participate in this symposium. The work I'm talking about today has been shaped by numerous collaborations with colleagues over the years, but in particular reflects work I've been doing recently with Pascal Sheeran and Bill Klein, and I'd like to recognize their important contributions. Now is a time of tremendous opportunity for those of us interested in strategies that can help people make and sustain changes in their behavior. The evidence is clear that behavioral practices have an important implication for health. How can we help people make sustained changes in their behavior? How can we capitalize on this moment, on this opportunity? Well, as is often the case with opportunities, there are challenges. And as I said, what do we need to capitalize on this opportunity? Are we prepared to provide intervention strategies that effectively and efficiently promote sustained changes in people's behavior? Well, we have no shortage of strategies, or what I might term tools, in our behavior change toolbox. And with the development of taxonomies, such as Susan Mickey and colleagues' Behavior Change Technique Taxonomy version 1, we have developed a better shared understanding of what the tools are in the toolbox. Furthermore, through the emergence of a range of initiatives, such as the science of behavior change, there has been an enhanced focus on developing a rigorous evidence base for effectiveness. And I'll talk a bit about that to come. However, evidence of effectiveness is necessary, but not sufficient. Interventionists and policymakers need guidance regarding which strategy or strategies should be used for which behavior, and whether the choice depends on for whom or the setting on which it is used. Thus, when policymakers and interventionists ask us what tool to use, they're asking a more specific question, right? They're saying, what tool should I use for the specific problem that I'm engaged in pursuing? And I would suggest that these are hard but fair questions to ask. Moreover, I would assert that these are questions we all want to be able to answer. I want to be able to open my toolbox and know when to recommend which tool. I'm going to propose that we need to develop an evidence base that can answer these questions, that can give us principles that are practical, that can provide the guidance the interventionists and the policymakers need, the guidance we want to provide, evidence that tells us not only that an intervention works, but the conditions under which it works. In my short time today, I'd like to just do two things. First, I'd like to emphasize the importance of embracing a mechanistic approach to behavior change interventions. And then second, I want to introduce a perspective or a framework that I've developed with Pascal Sheeran called the operating conditions framework, which I think may help us delineate the conditions under which these mechanisms operate. So now the first. Over the past 10 years or so, there's been a remarkable emergence of tools and frameworks designed to support the design and testing of behavior change interventions. You may be familiar with some or all of these. NIH's Science of Behavior Change Initiative, which is up on the upper left of your screen, the Orbit model developed by Susan Czachowski and her colleagues, Linda Collins's multi-phase optimization strategy, or MOST, and in the UK, the Theory and Techniques tool led by Susan Mickey and Mari Johnston. Although there are some differences between these different frameworks, they're all grounded on a mechanistic approach to behavior change, emphasizing that intervention development depends critically on mapping and testing the mechanisms that are theorized to underlie an intervention's effect. The mechanistic approach to behavior change has been termed the experimental medicine approach. And a key facet of this approach is the recognition that intervention effects are a function of two distinct change processes. On your screen, you'll see there's the validity path, which represents a target or mechanism of action's ability to elicit a change in behavior. And on the left, the engagement path, which represents the intervention or intervention technique's ability to elicit a change in that putative target. Thus, an intervention's effectiveness, its ability to change behavior, is predicated on its ability to engage a valid target. Identification of a poor or an invalid target, or relies on a strategy that fails to engage that target, will result in an ineffective intervention. Now, a central feature of the mechanistic approach to behavior change is the target, right? It is the mechanism of action that serves to link the intervention strategy with the targeted outcome. And a key question investigators must grapple with is which constructs to turn to, which constructs have been shown to be valid. Now, our theories identify numerous targets and might again be asked, of those targets, are there ones that have evidence to be as valid targets? Well, Pascal Sheard and I have examined the question of, well, what is evidence for target validity? And we've suggested that the most compelling evidence for target validity comes from experiments that can test the degree to which successfully eliciting a change in the target leads to behavior change. Or really, maybe put slightly differently, is to, if you've been able to change the target, how much of a change in behavior do you actually observe? And what we've done is identified 7 meta-analyses, one for each of the 7 targets on your screen. In this case, all focused in the domain of diet and physical activity, because that's where the data were available. And in each case, the meta-analytic synthesis was designed to examine the degree to which experimentally eliciting a significant change in the construct, for example, people's attitudes towards the behavior, leads to a change in behavior. And what the figure demonstrates is the D, or the effect size associated with that observed change in the behavior for each of the targets. And you can see that across the 7 meta-analyses, changes in the constructs led to a change in behavior. And that change was characterized by a small to medium effect size. And this indicates that these constructs can be used to elicit changes in behavior, and that is, they can be valid targets. Now, the mechanistic approach to behavior change suggests that if we could identify a valid target and an intervention strategy that can engage that target, our intervention should work. If only life were that simple. Evidence of target validity tells us what can happen, but a lingering challenge for the experimental medicine approach is that our interventions, even when they work, are often characterized by very heterogeneous effects. That is, what can happen is not always what does happen. To develop a broader sense of the degree to which heterogeneity is characterized, the degree to which interventions to change behavior are marked by heterogeneity and effects, Pascal Sheard and I identified all of the meta-analyses published in Health Psychology, Annals of Behavioral Medicine, and Health Psychology Review between 1999 and 2019. We identified 46 meta-analyses of health behavior change interventions and used the Q&I statistics to assess the degree of heterogeneity. What did we find? 38 out of the 46 meta-analyses reported significant heterogeneity. And I've shown you on the screen here the I-squared reported, which gives you the proportion of the observed variance that reflects variance in the true effect size. And you can see that the average I-squared in this sample was 61.2%. Heterogeneity in intervention effects appear to be substantial and quite common. Moreover, the meta-analyses revealed that the source of this heterogeneity remains very poorly understood. Although 40 out of the 46 meta-analyses tested for moderation, investigators struggled to explain the observed heterogeneity. Only 5 indicated the variance that could be explained, and the median variance accounted for was around 13.6. It's clear we need a new approach to understanding the sources of heterogeneity in these interventions, that our current approach is identifying that heterogeneity, but not really giving us a way to explain. With the operating conditions framework, we propose that investigators embrace from the outset that intervention effects may be heterogeneous, but that the source of that heterogeneity is lawful and can be specified. Working within the experimental medicine approach, the OCF, or the operating conditions framework, shifts the focus about moderation from a general question that says, well, what's moderating the effect of the intervention on behavior, to a pair of more specific questions. What factors moderate the 2 change processes that underlie the intervention effect? It urges investigators to not only specify the mechanism for the intervention, but to specify from the outset the conditions that are needed to be present for an effect to emerge. Under what condition is a target able to elicit a change in the outcome? Under what conditions is an intervention able to engage the target? In doing so, it links questions about moderation to questions about mediation or mechanisms, reminding investigators what our statistical colleagues have long recognized, that questions about mediation and moderation are closely intertwined. So let's take a look at what the OCF might do. It shifts how we approach questions regarding target validity, for example. Specifying the validity path now involves identifying a construct that is a potential intervention target and explicitly delineating the conditions under which the target is expected to be associated with the focal outcome. For example, it could be the nature of the behavior or the availability of resources or an individual's priorities. What it does is it renders the assumptions we are holding explicit. And I think it may be helpful to articulate at the outset what are the conditions might be for which the target would not be valid. The goal is to explicate these conditions at the outset and allow the investigator to plan to engage with the potential validity moderators. Of course, there may be situations where a target is always valid, but my guess is that this will unfortunately be the exception rather than the rule. The OCF similarly shifts how investigators approach target engagement. Here we ask, what are the conditions under which an intervention technique will elicit a change in the target? So now we're talking about engagement moderators or engagement moderation. Okay, so again, it could be the availability of resources, the priorities of the individuals, the source or the means by which the intervention is delivered. Again, the goal is to explicate these conditions at the outset and allow the investigator the opportunity to manage potential engagement moderators. Here you might choose to measure those moderators, you might choose to manipulate them, or you might even choose to fix them, to specify them from the outset. In that case, you're explicitly looking to see if the intervention works under those conditions. And all this allows us to develop an understanding of what strategy to use for what behaviors and for whom and in what settings. Now, to date, we actually know remarkably little about moderators of target engagement and target validity. None of the 46 meta-analyses reported data regarding the moderation of these processes, those 46 meta-analyses I referred earlier. And in fact, the initial review of the broader literature indicates that to date, investigators have not prioritized or considered factors that moderate these processes. And what has emerged, and we have a brief summary on the table 1 that you can see on your screen, seems more idiosyncratic than programmatic. I suggest that there's a clear opportunity and important need for investigators to contribute and address this gap in the literature. And so I would urge you that this would be something we might want to talk about after my presentation. So what might the operating condition framework afford? I'd like to suggest that it prioritizes the engagement with mechanisms and mediators and operating conditions moderators at the outset of our work. It shifts our focus from a post hoc discussion of boundary conditions to an a priori discussion of why and when interventions should work. It also offers us an expanded view of potential targets for interventions. For example, those in validity or engagement moderators that are modifiable might actually emerge as predictive targets. Changing those moderators might allow a target to be valid or allow an intervention strategy to be more effective at engagement. What else might the OCF afford? I'd like to suggest that it would allow us to generate an evidence base that is both practical and generative. It will allow us to generate evidence that can provide the guidance we want or we need in order to offer instructions and advice to the interventionists and policymakers. It'll allow us to not only say which strategies are effective, but which strategy or strategies to use for which behavior and for whom and under what conditions. And it gives us evidence that can be synthesized across studies that have measured potential moderators systematically. So individual studies might not always be powered enough to test unique individual moderators, but in the growth of open access to protocol and data, it would allow us the opportunity to synthesize data across interventions to begin to actually systematically observe the conditions under which different intervention strategies, different targets operate. And that the evidence that emerges might actually place pressure on theories and theorists to specify not only what are the key constructs, what are the constructs in a theory, but when those key constructs do and do not matter, and the factors that underlie those constraints. I want to thank you for listening to me and your time today, and I look forward to discussing it later in October.
Hello, everyone, and thank you so much for joining us at the Theory Symposium. I'll be talking about fuzzy trace theory and its implications for health and medicine. As usual, I'm trying to cover too much in one talk, so here are some recent references that explain what I'm talking about. The first two are short, free, and worth every penny you pay for them. The last one is a literature review that identified 94 studies applying fuzzy trace theory to health and medicine. Here are some examples that I'm going to be drawing on in the talk from medical decision-making, including rheumatoid arthritis medications, automatic evaluation of medical texts, especially those involving cancer, efficacy of a web-based intelligent tutoring system for communicating genetic risk of breast cancer, social media, and patients' and physicians' expectations for antibiotics. Briefly, fuzzy trace theory is a theory of how information from any source, the web, tweets, your provider, or friends, is mentally represented. The minute information leaves the page or the sound wave reaches you and enters your mind, it is mentally represented in multiple ways, as a verbatim copy of the surface form, the exact words, numbers, graphs, and so on, and separately on a different train track that runs in parallel to the verbatim representation. You mentally represent the gist of the information on that separate train track. The gist is the bottom line meaning. What does this piece of information boil down to? The gist is subjective and reflects everything about you, filtered through your knowledge and experience. The gist then cues your values and emotions. It's the meaning of the information, not the information itself, that determines how you feel and decide. You the patient, you the provider, you the policymaker. A given piece of information can be interpreted in different ways, and so it has different gist representations. Fuzzy trace theory explains why even when we know the facts, and even when we agree on the facts, we can still make very different, predictably different decisions. For example, you can view a person kneeling, and the gist of that action to you might mean respect and recognition of the need for justice. Another person views the same act of kneeling as disrespect for the flag and country. Both people are likely to agree that they value justice and patriotism. But the interpretation of the act of kneeling, the gist of kneeling, can be interpreted very differently, prompting sympathy or anger. What about medicine? Imagine that there are two parents. They both highly value protecting their children. One views vaccinations as toxic, as containing mercury and other poisons that explain the sudden childhood manifestation of autism in a previously well-developing child. To this parent, the timing and toxicity of childhood vaccines explains and gives meaning to an otherwise mysterious and inexplicable illness, autism. An illness that seems to be on the rise in tandem with the increasing number of childhood vaccinations. Another parent remembers the ravages of polio and sees vaccinations as having nil risk. Nil, what a fuzzy concept that is, but such a useful gist. Nil risk, but with a huge benefit. Naturally, that parent chooses to vaccinate. Medical information often doesn't convey what is nil and what is huge. We mistakenly believe that we have only two choices: to provide objective, detailed numbers or facts, or to persuade patients to do something that is good for them but that they do not understand. That's not patient-centered informed decision-making. Fuzzy trace theory says there's a third way: to explain the gist of the information and explain why you, the provider, think that is the gist. There are several practical advantages to this approach. It sticks longer, memory for verbatim details fades quickly, memory for gist endures. It's relatively short. You cut to the chase, streamlining but not dumbing down information. By the way, we always provide the detailed facts in our interventions. We are pro-facts, but facts alone are not enough. The patient has to not only comprehend the words and the numbers, they have to get the gist. What do those words and numbers boil down to make a good decision? Now, verbatim representations, as the slide says, capture those exact words and numbers. And verbatim representations can be an input to the operation of precise rote procedures like multiplication. So you might say, like on a numeracy test, 0.2 equals 1/5 equals 20 out of 100. You've memorized those equalities. If you calculate these by rote, if you memorize them and bring them to mind by rote, then that's verbatim processing. But not all numerical processing is verbatim. So one of the famous examples in Gestalt theory is finding the area of a rectangle. You might have memorized a formula, length times width, and then you're presented with a parallelogram. And do you just multiply length by width? A lot of people do that, but that's the wrong answer. Actually, it's the base times the height. So just invoking a rote memorized rule for that formula creates a wrong answer. And the Gestalt theorist's point was that you have to think, and in fact, they show how you can extract the area of a parallelogram based on understanding simpler concepts. So numbers and numeracy are not enough. Knowing that 20 out of 100 is the same thing as 1/5 does not tell you whether that gist is low or high, whether that risk is large or infinitesimally small in the great context of things. Numbers are as ambiguous as words, and sometimes maybe more so. So your representations, in fact, have to make a contact with your values. That's what makes value concordance. And values are represented in a fuzzy form. They're not precise either. Fuzzy trace doesn't say that values and emotions do not matter. On the contrary, emotions often follow predictably and reasonably from the gist. If you thought the government, with its huge powers, was forcing you to put your child at risk, you would feel anger. Almost everyone values freedom. But information plus misinformation and lack of knowledge must be interpreted to get the gist, and the gist determines the decision. Now, this example is actually from law, but it's a good example of how values and representations work together. So in this example, the blue line shows you those who are highest in gist by an independent test. And it shows the relationship between your value here, you wouldn't plead guilty to a crime you didn't commit, is in fact most sharply related to your choice, in this case, to plead guilty. When you're a gist processor, that's the blue line. The line that's almost flat shows the relationship between the values and the decision, the risky choice, when you are not a gist processor. So what this graph shows, and this is Rebecca Helm's fascinating idea, is that although the people who pled guilty and didn't plead guilty endorse the value of not pleading guilty to a crime they didn't commit, about equally often, the relationship between that value and their choices was highest for those people who were gist thinkers. So gist often boils down to categorical decisions, and categorical decisions are often what's represented in values, to non-negligible possibilities, not probabilities. It's the real possibility that one might get HIV that often guides risk prevention behaviors such as protected sex or abstinence. The objective probability is typically small for a single act. It's the possibility of HIV. It's the possibility of cure, not the low probability that may determine, for example, participation in a clinical trial. Researchers have concluded that patients do not get it, that patients do not understand sometimes that research, say for late-stage cancer patients, is not treatment. But what we might have here is a failure to communicate. The patient might be thinking possibility, while the researcher is thinking probability. Notice that the structure of many health and medical decisions is a choice between a certainty and a possibility. If the outcomes are all good, the outcome dimension is positively valued or valence, more years of life, more lives saved, then something is better than nothing. If the outcome is bad, if it's negatively valenced, then nothing is better than something. For example, no pain is better than some pain. This is the typical structure of gain-loss framing problems in decision research. And as you can see, these problems are typically structured as something for sure versus the possibility of something or nothing. So the framing effect is that you prefer the sure option for the gain and the risky option for the losses. And as you can see with this kind of structure, if you simplify it to its categorical possibilities, that would be your preference. We've shown that this categorical sum none gist explains framing effects, and we've ruled out the mechanisms of prospect theory in explaining these effects. Though I must say I love prospect theory and I've been heavily influenced by it. We've also modeled these framing effects. We, along with Broniatowski and Klein, I and they, applied these same predictions to patients' antibiotic decisions in the emergency department. If a patient shows up in the emergency department, he or she is pretty sick. So the gist of that situation for many patients is feeling sick for sure, or taking an antibiotic and either being sick, it doesn't work, or feeling better. Feeling better is better than being sick, so why not take a risk? So this was our prediction, that for many people it wasn't the case that they were unaware that their illnesses might not be treatable because they're a virus, but rather they were taking a strategic risk, namely that some chance that an antibiotic might make them better, as opposed to, well, it's essentially harmless and you stay sick anyway, which is what you already are. So think of this really as a loss frame. And in fact, this why not take a risk accounted for a large amount of variance in patients' expectations about antibiotics. This is real patients in the emergency room. Even when they realize that germs are not all alike, that viruses are unlikely to be affected by antibiotics, which are aimed at bacteria. The gist was possibility, not probability. We also thought that this gist might be endorsed by healthcare providers, all of whom would know that viral illnesses were not treatable with antibiotics. By the way, we checked, and they did all pass that test. Despite the symptoms clearly indicating the likelihood of a viral illness, even a large proportion of doctors and other providers endorsed the gist-based strategy of why not take a risk. This gist naturally assumes that the harms for individual patients from unneeded antibiotics are nil, but that assumption is false. Again, the gist is the same as the loss decisions in a framing problem. Something bad for sure, you're already sick, or taking a risk. And maybe the outcome will be bad, and maybe the outcome will be good. Might as well take a risk. So the gist that a person extracts from information is not always the correct gist based on expert knowledge. Whether information or misinformation, Braniatowski and colleagues hypothesized that messages that make sense on social media, they make sense of threatening and uncertain events, will have greater influence than messages that do not have a gist. So they did an analysis during the Disneyland measles outbreak of social media, in fact, Facebook posts. They had human judges evaluate many Facebook posts for whether they conveyed a gist, as well as whether they had a story or an image, and so on. The latter were assumed, those messages that had an image, those were assumed to be more vivid than just plain old text. What they found, as shown in this slide, is that the probability that a Facebook post was shared was a function of whether it conveyed a gist, as well as whether it contained statistics, controlling for length and readability. Stories by themselves were not shared more often once gist was accounted for. So to take a bigger picture, what works? Note that there is such a thing as motivative reasoning in fuzzy trace theory, or my-side bias. And there is such a thing as providing facts. Facts are good. Knowledge is always in the equation, and gist depends on knowledge. Gist, however, provides a way to reach people when it seems as though they are simply non-adherent, biased, or lack facts. When people do have the facts and value what we think makes sense, or what many of us value, why don't they make decisions in their own interests? Decisions that accord with their values. Often they don't get the gist, but healthcare educators and providers can effectively communicate that gist. So here you see an overall model that starts off with information. Maybe it comes from the web or from your provider. You take that information in, then filter it through your knowledge. Then you extract the gist representation in tandem with the verbatim representation. That gist or interpretation gives rise to certain feelings and evokes certain motivations and values. And the more that the message incorporates a gist and makes us feel, the more likely we are to share that message. And on the cycle goes as it becomes informational inputs to other people. I want to thank the organizers, the National Institutes of Health, who have supported my work for many years, the National Cancer Institute, HIV prevention, and the National Institutes of Nursing Research, the National Science Foundation, PCORI, and all the wonderful staff, students, and colleagues. I want to welcome you to our discussion section for theories of medical decision-making explaining, predicting, and improving health and healthcare. Now, if that's not enough, you get a free cooking lesson from Olga. Thank you all for coming. I do not see any questions yet, but I want to throw one out to one of our participants just to get the ball rolling. And Ken, this one is for you. You mentioned, of course, and talk in very interesting terms about autonomy and other directedness and patient-centered versus provider-centered. Currently, we happen to be in a pandemic, and policymakers are faced with the dilemma of, do they mandate things like wearing of masks? That's clearly an example of other directed, and there's all kinds of political fault lines associated with that. But I want you to tell us, what would you tell policymakers based on the research on the psychology of this?
Great question. So we actually have an article in Press where we measured COVID protective behaviors, trait reactance, conspiracy beliefs, and belief in the apocalypse. And those three all predicted in the expected direction, not wearing a mask or social distancing. So I'm on a couple of panels working with NIH on a vaccine hesitance campaign they're going to do, and we're actually working with HBO to try and put some characters into some storylines that specifically handle the skeptic. How do we handle that reactance, that I don't like being told what to do, and that not wearing a mask has become an act of autonomy? So the communications challenge, which is behind your question, is how do you make mask wearing an expression of autonomy similar to general vaccine hesitance? It's been very hard to counter message that particular challenge. So we've come up with a couple of strategies that we're going to be testing. One is, of course, having both the health education source reflecting back to the skeptic. You're right, the government can't always be trusted. You're right, sometimes they hold things back. You're a person who really thinks about these things a lot. So give some affirmation to disarm them rather than to instill sort of that defensive reaction. And then try and use some other techniques, soft pedaling, to say this is something that may or may not affect you, that tentative language I talked about in my talk. This has affected some people, not others. And the other strategy we're trying is to create this character called the protector of the family, that you yourself are a risk taker. On your own, you're going to go out on your motorcycle, you're not going to wear a mask, but for the sake of grandma, it might pay. So we're testing a variety of ways to see if we can convince the skeptics or the people who view it as an act of autonomy to not adhere to recommendations, to convert that into autonomously protecting your family and who's vulnerable, that will preserve masculinity and preserve other aspects that not wearing a mask or practicing protection seem to symbolically represent.
All right, well, and the example you give of smoking is an interesting analogy here. And of course, some of that has become mandatory and some of that remains autonomous. But it's a policymaker's dilemma, which science could inform. We do have a question in the chat box, and I will read that. And how is theory best derived? Individual studies, meta-analyses, nationally representative surveys, randomized trials with mediator and moderator analyses, including in randomized subgroups. Ellen, would you like to take that? You responded.
Yeah, I just said yes. So it depends on what you mean by best derived. It comes from a lot of different sources, but over time, all of this should be happening. Maybe the nationally representative surveys might not be necessary. It depends on what it is that you're doing. But it requires all of those pieces. And besides that, a lot of careful thought about what it is that you think is happening and how does it fit in with what we knew before. So it's not only about producing new data, it's also about understanding what came before and developing further beyond that.
Yeah. Building on a foundation of rigorous knowledge, not reinventing the wheel, and then testing hypotheses, right? As opposed to just illustrating them.
Valerie always does this better.
Oh, no, I love what you said. Alex, is this something you want to tackle?
Well, actually, I was actually gonna ask Stacy if she's willing to chime in here, because I had the same question that I think Ellen sort of led with, which was, what are you thinking about when you're saying derived, right? So are you thinking about sort of generating the theory, or are you thinking about testing the theory? I would be just curious. Both. I don't know if Stacy, if you're up for unmuting yourself and chiming in. And by no means you're not obligated. It's just I'm obligated to talk. You aren't. Oh, okay, cool. Thanks, Stacy. I saw the text. So generating
and testing. Working on unmuting.
Yeah. Yet, I think actually it's a good question. And sort of, I guess maybe then I will fall a little bit back on what I guess both Ellen and Val said, but particularly Val, which is, it really depends on sort of where the evidence base is that you're working from, right? So typically you're hardly ever in sort of a completely sort of de novo state, and so the real question really becomes sort of where you are, and then which of these strategies probably is most appropriate given the state of the evidence and what the question is. For what it's worth, I tend to actually believe that we spend too much of our time thinking about testing and not enough of our time thinking about generating, right? So in other words, I would advocate quite strongly that there's a lot of value in time spent in the sort of hypothesis generation phase to just make sure that you've really specified the theoretical question that you're interested in as precisely as you can, and that really helps sort of guide where then is what might be the most appropriate strategy to use to then to test that hypothesis.
And you have a framework for that, a kind of blueprint into which people can put various things.
Right, we've got one, and other people have things. But I think but in some sense, the sort of really the thinking carefully about what kind of data you need to answer the questions you're interested in answering. I often find that people have really interesting questions. They often generate really interesting data, and then unfortunately, sometimes there's just too much of a disconnect between those data. They don't actually address the question. But yes. Val, but you've probably seen we've got a bunch of questions here.
Yes, we do. And I'll read the next one. All of the talks were so interesting. Thank you to the panel. I was thinking about the autonomous versus directed communication. One can be hesitant, wishy-washy, for lack of a better term, when engaging in autonomous style communication, and one can be hesitant, wishy-washy when being more directive. For example, we recommend vaccination versus, well, some experts think vaccination has the strongest evidence behind it, so we tell our patients they should consider getting vaccinated. Has there been research unpacking the language and message delivery rather than the style?
I think that's you, Ken.
Ken, did you want to grab that one?
Yes, so in general, there's okay data that tentative tone is less likely to trigger reactance. So although it's not always the most effective tone, and I'll get to that in 1 second, we have some decent data from the MI world, motivational interviewing world, that when you say things like it may not work for everyone, everyone's a little bit different, that lowers reactance. One of the most interesting things that has gotten very little attention, but I hope people start researching, is this idea of presumptive intervention. And it's this idea that in some situations, including the smoking study I mentioned, it may actually be more efficacious for a physician or a healthcare provider to simply say during, let's say, a health maintenance exam, and by the way, your prescription for the flu is outside, as is a prescription for Chantix and Lipitor, and not actually go through shared decision making. And the net benefit to society is some people will still turn that presumptive offer down, but the net benefit may be more people end up using their Chantix, quitting smoking, and taking their Lipitor. So one of the dimensions I'd love for folks in this world to start to look at is what is the benefit, if anything, it could be harmful. Presumptive intervention could be very reactive. How dare you assume I want Chantix and want to quit? But what is the net benefit to society of trying to have messages like, I'm just assuming you're going to do this, and now the inertia is in that direction.
And what about epistemic uncertainty? How does that, cross-cut this? Because your language is going to be more tentative if the facts are more tentative. So how do you pull those apart?
So I think in MI, even if the facts are pretty straightforward, we often still use tentative language. So even if 99 or 100% of the studies agree on something, which is rare, but if that happened, we still tend to put a little meat tenderizer on that and say that not everyone agrees, or things like that, so people don't feel boxed in a corner. The part, though, I do want to just get in before we move to the next question is, I do think there's a matching issue. There's individuals who want a definitive tone. And for those people, the wishy-washy tone might be iatrogenic. And then there's people who don't want, we lovingly say it's the difference between the Fox News audience and the NPR audience. And someone who really likes being told what to do and likes moral terms, wishy-washy is actually often rejected. And we need much more research in that, but that's been our findings so far.
Hey, can I insert a question?
Yes, please.
I was curious, Ken, you've talked a bit about wishy-washy language. You've talked a bit about, I can't remember what you labeled it, but with the pandemic and mask wearing, kind of freedom language along with affirmations. What you haven't talked about at all is providing like numeric evidence, providing data. And have you looked at that at all within these various studies? I'm curious what those effects are, because we've seen some interesting effects of providing numbers with things like, but there are things like prescription drugs, for example.
For that, I should divert to Angie and Brian, our two hardcore decision-making people in our team. But we have found there's a technique we use called elicit, provide, elicit. And before we provide information, we still try and get autonomy. So we usually say, what's the information you most need? What would help you make this decision? So even when we have really good data, and it can be what we call surprise data or sort of data that you already know and you're just confirming, we still feel it's critical to lay the ground and soften the ground by letting them have some choice in the matter. How much you want? Do you want me to send it to you by email? Do you want a website? And we find that when we provide them with choice, that's the elicit part of elicit, provide, elicit before the P part, provide. It increases the absorption.
Excellent. I want to go to the next question from Scott. And I know people can read these, but the question I get most from my students is, can parts of various theories be combined when developing a survey or intervention? My default answer is when you pick and choose, then you have to reestablish reliability, validity, and cannot assume the metrics of the original theories apply. And then Alan responded to Scott, are your students asking about combining theories per se or about combining instruments intended to measure theoretical constructs? And Alex, why don't you take that, because you've actually talked about combining theories quite at length, combining meta-analyses even.
Sorry about that, I had to unmute. So I was thinking the same question that Alan posed. So, and so again, I guess I'd almost want to ask Scott here to clarify here. So when you say you want to reestablish reliability and validity here, again, the question sort of is lurking in sort of the reliability and validity of what? Of the sort of hypothesized relations between constructs, right? And so, or as I think Alan was talking about, is it the instruments used to measure those constructs? I think if it's the relationship between constructs, I think you can. I believe you can propose, or at least assert, the possibility of linking relations that are specified in different theories and then mapping them together. I mean, that can often be a very strong and plausible hypothesis. You may have hypotheses that, or you may have theories that are particularly good at about providing information, but then theories that are more about action and implementation, and you could merge those together. I just think, I think what's lurking under your default answer is, you do anything like that, you need to be just thoughtful about how you're doing it, right? You need to be thoughtful about the assumptions that are carrying forward and whether the evidence that's available to support relations under one theory are actually the evidence you need as you're moving with just part of that theory, right? So do you know what I mean? So in other words, so that there are, you know, if you're going to just take a sort of a specific principle of one theory and sort of borrow it and embed it in another theory, you just need to make sure that the evidence available is actually, you know, can support the piece of the theory you've excavated out, if that makes sense.
It does, yeah. I think a lot of what my students are interested in doing is, and perhaps I'm blaming it on my students, maybe I do it too, but what they want to do is say, all right, we're going to apply theory of planned behavior, but we're also going to bring in some social cognitive theory, and we're going to take this piece from here, and then we're going to throw it all in together in a single survey, and then try to make a conclusion based on sort of the relationship between the parts, like you're saying.
So if I could just jump in for a moment here. So my sense of that is that it's not so much that you couldn't do that kind of synthesis, but that kind of synthesis to be productive really needs a lot of really careful preparatory planning and thinking, right? And you know, so, and then I just say in general, we don't necessarily see that, right? So in other words, you really sort of need to be carefully mapping out what do you think are the relations then between those different constructs. I mean, sometimes it's almost like, why do you want to bring the, why, you know what I mean? Why do you want to bring them together? I mean, and you know, I think there is almost
because
the
they're
implicit,
there, the Mount Everest theory.
Right, this is right, right. That
unifying
more
theory.
Right, the more is better idea, and I think probably most of us around on the call sort of realize in our own experiences that less is often more, and it sort of goes back in my mind to sort of state back. It's a variant of the response to Stacy's question, which is just then, okay, once I understand what you're trying to do by bringing, what are you trying to capitalize? What are you trying to be able to now do by bringing those two things together? We can then begin to figure out, okay, so what parts of those, that synthesis that you're after, what are then the gap? What are the evidence gaps, right? What do we then need to know in order to move forward with that restriction?
And always, as you all do in your great examples, all of you, of building on the prior literature, as we mentioned before. When people, you know, have asked me on committees, you know, what should we do to improve our rate of replicability? And of course, the answer is read the literature, but that's very hard.
Thanks, Alex. I appreciate it.
And Scott, if you want to add some additional things, just feel free to join in. I'm going to read the next question. What is the opportunity for meta-theories of decision-making, combining and testing the relevant proven relationships from individual theories in the same population, and holding extraneous factors constant, holding, I assume. Ellen, did you want to take that?
Do I want to take that? What is the opportunity for I'm trying to actually parse the language, Stacy. Meta-theories of decision-making, combining and testing.
So taking different elements, just as we were talking before, and putting them together, the reliable components of different things.
Yeah, I mean, it can be. So I think this actually goes back a bit to what Alex was just talking about. And you're thinking of something like Michie's framework for the behavior change taxonomy. So I actually don't know that framework well enough to comment on that. But you know, I think it does go back to thinking carefully through what do you know about the original theories you're thinking about. And I wanted to add something to what Alex was saying before that I think is relevant here too, which is sometimes part of what you can do is you can take a couple of theories, but realize, for example, if we go back to something that Alex was talking about in his talk, think about how a concept from one theory might actually be a moderator in another theory. Mm-hmm. And so looking to, in a sense, using theories to test each other and understand better what are the moderators and mediators that are involved here. And so I think that again, it takes careful thought. You want to think about what is it that you know from the past literature, and carefully considering, how is it that I would combine these things, and what would I need to measure in order to tell what's going on?
I think, yeah, Alex, I can see your hand is up.
Oh,
Go right ahead.
Yeah. I think I'll just offer as just a point to look here, Stacy, and then maybe it taps. Actually, it also speaks maybe to Scott's question too, which is, I don't know what people are familiar with or not, but Linda Collins's MOST framework, which is the multi-phase optimization strategy. If you're not familiar with that, she's got a wonderful book that describes her whole framework that's available, and I would get often available for free in your library virtually. I would encourage you to take a look at that, where she's really giving you a framework to think sort of very strategically about the whole experimental process of sort of manipulating different pieces of an intervention. And so I'm going to embed Stacy's idea within a more of an experimental framework, and then mapping carefully the relative paths in which you think those different intervention strategies are going to produce the outcome that you're interested in and hope to obtain. And in Linda's framework, it gives you a way of sort of trying to figure out which are the pieces that actually matter, right? So, you've got these different proven relationships, but we sort of, in some sense, which of the strategies and which of the intervening, the hypothesized, what are typically our theoretical constructs, which matter in terms of driving the outcome you're interested in. And that is a framework for, not always used this way, but it's very much could be a framework for use for looking at the relative strength of different theoretical principles.
Yes, and one of the things I've tried to do in fuzzy trace theory is integrate lots of things. I think that's more a comment about my cognitive style necessarily, because I very much agree that, there's motivated reasoning, but then there's simply not getting the gist of the information. And one of my approaches analytically is to think about what unique variance is accounted for by very different ideas and try to put them together. And again, building on the prior literature, that's very important. So, and I know all of you to some extent are good examples of doing exactly that. Of course, we are putting together things from multiple investigators in different schools of thought. That's one of the reasons why we selected you. One of the things we want to avoid is these meta-theoretical frameworks that have no content. They have no testable predictions. Arrows go in every possible direction, and they pretty much can't be wrong. There's no falsification. Those are too general. But if you take all the component elements seriously and testably, meta theory may be a very productive way to go. So we have another question. It says, in more than one of the presentations, you talked about wrong decisions. I was wondering if you use the word to some extent in a normative sense here, or more generally, what are your thoughts on ethical implications of theories of medical decision-making? Would anybody like to jump at the question of how we decide what's wrong and whether we should do that? I don't blame you.
Does anybody remember who said?
Well, I think about this a lot, and I worry very much about it. And I always hear Baruch Fischoff's voice in the back of my head saying, respect the autonomy of the individual. And of course, he's right. So when we presume to say what's right, that is a very dangerous thing to do. On the other hand, if we never say anything is right, then the patient, that doesn't really help patients and people either. So I'd like to think of separating out these elements. Right in what sense? Naturally, we've talked about value-sensitive decisions, and there, the right answer is value-concordant decisions. So there's no one right answer. It depends on your values. And that's certainly been, that's characteristic of many people's work. Then, however, I do think there are times in which we say risks and benefits, we treat them equally in an effort to respect people, a good goal. But what we do is we create complete confusion about what the gist of the actions are. When the evidence is 90%, 10%, and we're telling people 50-50, we're in fact misleading them about the gist. So, and this is something that I worry about too. So as with all moral and ethical decisions, you know, there's no avoiding them. There's no go to your neutral corner, especially if you're interested in applied work, and don't take a stand, because you have to think about suffering and death. And that's the ultimate outcome, suffering and death. And if you can alleviate that, for most people, most of the time, you have to take on that moral and ethical burden, I think. So that's the kind of struggle I've had. I don't know if anybody else wants to join in on that.
For me, there are a couple of dimensions here. One is we like to divide decisions into preference-sensitive decisions and directional decisions. Two good preference-sensitive examples are colonoscopy versus FIT or FOBIT, because both about the same outcome. Another one is breast-conserving surgery and mastectomy for most early-stage non-metastatic breast cancers. In those cases, counselor, the physician, whoever is in a state of equipoise, you have no position. But in persuasive situations like quitting smoking, our goal generally is a high quality decision. And that means that we always say there's 5 elements. I had enough time, I had enough input, I had enough information, you respected my autonomy, and I'm happy with the outcome. And that if someone under those circumstances chooses to quit smoking, to continue smoking, and it was informed and autonomy supportive, that we would still classify that as a high quality decision, even though it goes against our public health ethos of extending the quantity of life. That's a value we have that our patients may not all have. So I do think the frame is not right or wrong, but it's sort of high quality and low quality decision making.
Yeah, I think that really helps a lot. But it still leaves the following dilemma that I've struggled with too, and that is, you know, if someone would know, and in particular, for example, with adolescents, this is a little bit easier to think about, because we know that their decisions when they're teenagers are going to be different than the same person would make for themselves later in many respects. So this is also true of people that attempt suicide and so on. The person of the moment is not the person later, and they'll regret certain things, and we can know that in a predictable way. That's not true for everyone, of course, but that's true in general. So one of the things I've argued is that there's something in between persuasion and facts. And you have to make sure that someone's not saying, I feel informed, but they're actually not, right? I'm a satisfied customer, but meanwhile, I've had an unnecessary amputation, you know? But I'm very satisfied because the doctor was, you know, physicians were nice to me, and you know, everything seemed right. So I think there's an intermediate between telling someone facts that they don't get the point of, which would be getting the gist, and then their values as a separate matter, as opposed to persuading people of things that they don't really want to do, or just giving them facts and leaving it up to them to pull out of it what the point of it is. And this is often, I think, why patients say, what would you do, doc? You know, if this was your spouse, what would you do? They're trying to get a sense of, well, if I put all this together, what does it boil down to, in my opinion? Okay, so we have another question about group decision-making. Has there been any discussion of theories of group decision-making as opposed to individual decision-making? And theories that link individual and groups. And this person is interested because decision-making for improving health and other outcomes can occur one patient or citizen at a time versus decisions by multiple decision makers.
I think
Ellen,
the easy answer is no. Sorry, Kathy, but the easy answer is no. You didn't miss it, and I will just, you know, I unfortunately that's all I can offer at this point. I mean, my work just doesn't. I recognize the importance of the question, and I would say I don't think that's a major focus. I don't know if, I mean, I do where there is growth, I would say, but I don't know if this is exactly what you're thinking about. There is a growth in trying to synthesize what we know about interpersonal relationships. So it's more at the dyadic level and health, social cognitive models of health.
And I think we're at time, but go right ahead, Ellen.
Oh, I was just going to say,
I think this is at some point, but
I really just wanted to say, I think this is an area of research that we need more of. I know very little in this area, and yet it is so critical within the kind of health decisions that we've been talking about throughout this whole session. you know, even an individual smoking cessation kind of decision, it's about the family too. It's about the people around them.
Yes,
Thank you all.
indeed. Well, I gather we are at 4 o'clock. Is that right, Dominic? We're going to have to end our session now. He may be with another person experiencing, but anyway, I believe we only had 30 minutes unless somebody knows better. I'm sure that the investigators would be delighted to have your questions. You can contact them through the interface. There's a way to send a comment or a question, and your email will be sent. So please contact them. They're also very easily available by going to your favorite search engine. I want to thank everybody. The talks are terrific. I've looked at them more than once, and each time I get something new out of the talks. I think they're a wonderful plan for the future of our field. And I think COVID-19 has really illustrated for us how all of these levels of analysis, where we made artificial distinctions before between health and medicine, for example, and many other aspects of social and economic disparities, are all connected. And I think theory offers an entree to addressing those problems. I just want to thank these terrific speakers. Thank you so much. Take care,
Thank you, Valerie.
everyone.
Thanks to everybody.
Yeah, thank you for coming.
Thank you.
Thank you, everybody.
Bye.
Thanks for your questions.
Thanks everyone for coming too. We really appreciate it.